You know, when you think about brain surgery, you probably picture the surgeon, right? The one with the steady hands. But there's someone else in that room, and our entire job is to be the brain's guardian. We're there to create the perfect conditions for the surgeon to work, and honestly, our entire day revolves around solving one single massive problem.
And this is it. This is the question that defines everything we do. Your skull is essentially a sealed bony box. It doesn't stretch, it doesn't give. So, what do you think happens when the brain inside it starts to swell?
Exactly. There is literally nowhere for it to go. That pressure has to go somewhere, and it starts squeezing everything. We call that intracranial pressure, or ICP. And managing it, well, that's the whole game. If that pressure gets too high, blood can't get in to feed the brain, and that can be an absolute disaster.
So let's walk through how we do it. We're going to start with the game plan we make before we even walk into the OR. Then we'll talk about controlling that precious space inside the skull. We'll look at some really specialized surgeries, what we do when things get dangerous, and finally, we'll cover the delicate art of waking the patient up safely.
All right, so first things first, the plan. You might think the real action starts when the surgery begins, but for us, a successful case is built on the strategy we map out beforehand. It's a detailed discussion between me and the surgeon. Think of it as our pre-flight briefing.
And I mean, we go over every detail. We're talking, okay, how exactly will the patient be positioned? Are we going to use steroids ahead of time? What are our hard limits for blood pressure and carbon dioxide? We assess every single risk, like a potential air embolism, and we tailor the plan for this one patient for this one specific procedure.
Steroids are a perfect example of this pre-planning. A drug like dexamethasone is fantastic for reducing the swelling you see around tumors. But here's the thing, it's not a magic wand. You have to start it at least 48 hours before surgery to have an effect. It's a planner's tool, not an emergency fix. And just as important, we have to know when not to use it. For a traumatic brain injury, it's a hard no. Studies show it's actually harmful, so we stay far away from it.
Okay, now we're in the operating room. My mission here is to control the 4 things that take up real estate inside that skull. The brain tissue, the fluid in and around the brain, the cerebrospinal fluid or CSF, and, of course, blood. By manipulating those 4 things, we control the overall pressure.
Our choice of anesthetic is absolutely critical here. Intravenous drugs like propofol are our go-to for a tight brain, one where the pressure is already high. Why? Because they lower the brain's metabolism and decrease blood flow, which helps the brain relax. The inhaled gases, on the other hand, are vasodilators. They open up blood vessels. That can actually increase blood flow and jack up the pressure. When you've got no room to spare, that's a risk we just can't take.
And this quote just says it perfectly. When the brain has no more room to swell, no more compensatory latitude, you have to be prudent. You avoid anything that could push things over the edge. So a lot of the time, we'll just skip the inhaled anesthetics entirely just to be safe.
We also have a whole toolkit for actively lowering the pressure during surgery. We'll often start with mannitol, which is an amazing drug that literally pulls water out of the brain cells. Then we might give furosemide, a diuretic that helps the kidneys get rid of all that extra fluid. And if we need to drop the pressure fast, we can hyperventilate the patient. Lowering their carbon dioxide makes the brain's blood vessels constrict, and that gives us a quick, temporary fix. Now, in cases of traumatic brain injury, it's not just about lowering pressure, it's about making sure enough blood gets to the brain. We call this cerebral perfusion pressure, or CPP. And this number right here, 60 to 70, that's our target. We are constantly fine-tuning the patient's blood pressure to keep their brain perfusion right in that sweet spot.
Here's something that might seem a little backwards. We're usually obsessed with tight blood sugar control in medicine, but for an injured brain, it's a different story. That brain is under so much stress, it's burning through energy like crazy. If we get too aggressive with lowering its glucose supply, we could actually harm it. So, as strange as it sounds, sometimes an injured brain needs a little extra sweetness.
So, we've covered the general game plan. But no 2 cases are ever the same. Now let's get into some of the really specialized scenarios that require us to be incredibly precise and adaptable. The awake craniotomy. This is one of the most remarkable procedures we do. Yes, we actually wake the patient up in the middle of their brain surgery. Why would we do that? So the surgeon can map out exactly where the critical functions are, like the areas that control speech or movement, before removing a tumor. It's how we protect the very things that make a person who they are.
So how is this even possible? Well, here's a cool fact. The brain itself feels no pain. The scalp, on the other hand, is incredibly sensitive. So the whole foundation of an awake craniotomy is a meticulous scalp block. We carefully numb every single one of these major sensory nerves so the patient is completely comfortable and pain-free while they're awake.
When a brain aneurysm ruptures, the danger is far from over once the bleeding is controlled. There's a delayed complication called vasospasm that we're always watching for. And look at this timeline. The peak risk is 4 to 10 days after the initial bleed. The arteries in the brain can suddenly clamp down, cutting off blood flow and causing another stroke. Our vigilance has to extend way beyond the operating room.
Okay, next up are two really critical complications, where the very air we breathe becomes the enemy. And these moments, our continuous monitoring and our ability to react in seconds, are what make all the difference.
A venous air embolism, or VAE, is a potentially catastrophic event. It happens when air gets sucked into an open vein. This is a huge risk anytime the surgical site is higher than the heart. That air bubble travels straight to the heart, where it can block blood flow to the lungs and cause immediate cardiovascular collapse.
And the surgical position makes a massive difference. The sitting position gives the surgeon amazing access, but just look at that risk. The incidence of VAE can be as high as 76%. It's a huge trade-off. That's why if we have to use this position, we are on hyper alert with our most sensitive monitors, ready to act in a split second.
The moment we detect a VAE, this emergency drill kicks into high gear. We yell to the surgeon to flood the surgical field with saline. That stops more air from getting in. We try to aspirate the air directly out of the heart through a special catheter. We slam off the nitrous oxide, which can make air bubbles expand, crank up the oxygen to 100%, and start pushing drugs to support the blood pressure. It's a coordinated, lightning-fast response.
The second threat is something called tension pneumocephalus. This happens when air gets trapped inside the skull after everything is closed up. If we've been using nitrous oxide, it can seep into that trapped air pocket and cause it to expand fast. It ends up acting just like a brand new tumor, compressing the brain. This is exactly why we always stop the nitrous oxide well before the final closure.
All right, the surgery's done, the last stitch is in, you'd think we could all relax. But for us, one of the most critical and delicate parts of the whole day is just beginning. It's the wake-up. And in neurosurgery, a calm, smooth emergence is absolutely non-negotiable.
Our goals here are simple, and they are absolute. We want zero coughing, zero straining or bucking against the breathing tube, and zero sudden spikes in blood pressure. Why? Because any of those things can cause a surge in intracranial pressure, which could cause a devastating bleed at the surgical site or undo the surgeon's delicate work. A smooth wake-up is the final step in protecting the brain.
And that, really, brings us to the central challenge that defines our specialty. It's this constant balancing act. On one side, we're using science to exert precise, second-by-second control over the body's physiology. And on the other, we're dealing with the most complex, unpredictable, and frankly, awe-inspiring organ in the known universe. Finding that delicate balance? Well, that's the art and science of neuroanesthesia.